Joe and Hampton, lights dim, it's game time. Interview sharp, cut through like a shank line. Stick lounge, stories unfold, real and raw. From hustlers to dreamers, breaking laws with a claw. Microphone warriors, capture.
All right, Stick Lounge Podcast. We are back, everybody. Took a little bit of time off. I'm happy to be back. I haven't got to play with the board for a little while.
31 days.
All my sound effects for Hampton. Got that one. Which we're not going to get into it, but I saw the game today, so
Blood pressure high right now.
we're going to jump right into it. This is a special one to both of us, to me especially, for my daughter. I want to introduce Dr. Brooke Winner. How are you?
I'm fantastic. Thank you. Thank you so much for having me.
Yeah, thank you for coming. So we were talking a little bit about this out there in the lounge. This has all been kind of a whirlwind for everybody. Started a podcast, didn't really know why, just did it. Hamp and I were like, let's go, we're going to do it. Met a young lady, didn't know why. Found out the young lady had endometriosis. That was a hell of a story to hear from her. Immediately, had my daughter look into it, and long story short, now we're here. And you were my daughter's surgeon.
Yeah.
And the specialist.
Just six days ago.
Yeah. It happened very fast.
Yep.
It really did. So go ahead.
And not to jump to the punchline, but you guys were right. She had it.
Yeah.
No, since you said that, my question is, how did everybody else miss it? And how did you come up to diagnose it? And why is it not shown on the CT scan?
Well, that's the $1 million question. Why do all the other doctors keep missing it?
Yeah.
I don't really know the answer to that. I mean, it's a pretty predictable set of symptoms.
Mm-hmm.
But the problem is it doesn't show up on imaging because the spots are just too small.
Right.
Sometimes it can show up as a cyst on the ovary, but most people don't have that. And so, diagnosing it requires a surgery, and that's, we can do it minimally invasively, but it's still a big deal, right? It's still a surgery.
Now, and that's the part that people that I've talked to don't understand. They're like, well, how do you know that she has it? I'm like, it's symptoms, really. I mean, and I want to get into that, but first, and I can cut this out, maybe fix your mic just a little bit.
No, is it too low?
Yeah. There you go.
That better?
You can bring it into you a little bit too.
Yeah, get comfortable.
Get
Wherever
up and personal.
There you go. Yeah, and if you want to set up straighter, just it'll move for you. So just make it work for you. There you go. Okay, cool. What I want to get into a little bit is your backstory.
Yeah.
So how did you get to where you are now? I mean, obviously medical school, and did you start in, well, I'll let you tell the story. How did you get to where you are now as a specialist for, it's endometriosis and fibrosis, correct?
Fibroids, yeah.
Fibroids, thank you.
So I went into OBGYN because I was interested in women's health, and I really liked the idea of doing a little bit of everything, delivering babies, doing, long-term longitudinal care with women, and doing some surgery, but not all surgery. And then as I got further and further into my OBGYN training, I realized that surgery is really pretty complicated, and if I was going to do it, I wanted to do it really well. And doing it really well, in my opinion, requires doing it all the time. Right. And so I started realizing that the field of general OBGYN was really just too broad for me to feel comfortable operating. So I ended up doing a fellowship, 2 years of extra surgical training after the regular OBGYN training. And then ever since I've been in practice, I've never delivered babies. I don't do routine care. All I do is laparoscopic surgery for uterine fibroids and endometriosis and other things that aren't cancer.
That's crazy.
So that was my path.
So did you have to, was it a big extra bill for you to take that extra 2 years in a fellowship, or was that hard?
Yeah, I mean, you just get paid like a trainee for those 2 years instead of getting paid like a full-time independent doctor.
So it's not, you can't actually do that in college. This is outside of college that you're getting that training.
Yeah, so in college, you do sort of your pre-med requirements like chemistry and physics and that kind of stuff, biology. And then you go to medical school, which is 4 years. The first 2 years are kind of book learning. The last 2 years are the clinical rotations in the hospital. And you're rotating through everything, family practice, orthopedic surgery, OBGYN, pediatrics, et cetera. Then after the 4 years of medical school, then you go to residency, and that's where you pick your specialty. So that's where I did 4 years of OBGYN. And then after that, I did the 2 years of minimally invasive gynecologic surgery.
It's been a long.
Yeah. So I don't know. I think it's like 12 years of training or something crazy like that. So
that is crazy.
It's a lot.
So during this path, and you wanted to focus on surgery, you wanted to specialize in that. Did you know it was going to go to fibroids and endometriosis, or?
Those are just kind of the two most common benign conditions that need surgery. And so that's just sort of what the majority of my practice was. Most minimally invasive gynecologic surgeons like myself, that's kind of most of their practice. So,
Okay.
yeah.
Since the two people I've known that had it, they're both young. Is that something that's common in young women, or older women have the same problem?
It is common in young women. We are sort of used to diagnosing it in older women, but as there's been more awareness about diagnoses and women's health and believing women, believing their symptoms, I think people have started to get diagnosed younger and younger. And often it's diagnosed during an infertility workup. So if the woman's having trouble getting pregnant, sometimes that's the first time it's diagnosed.
Right.
So that tends to be younger women. But yeah, it can be a spectrum. And as you know, women wait on average 7 to 10 years to get diagnosed with endometriosis after their first going to the doctor to talk about pain. So that's a long time.
Well, and Michelle, that we interviewed on the podcast from Salon Michelle, she had it, and she had 7 surgeries over time to try to get rid of it, or at least make it better for however long you can. And eventually she had a hysterectomy at 37, and that's how she
Just
got rid
take
of it.
everything out.
Yeah, just take everything out. That's crazy. So there's no way to detect it prior to surgery. You're basically going off of symptoms. And I know that when you saw my daughter, when we left your office, you were pretty sure that she had it.
Yep.
So what are the key things that a young lady should look for? What are the things that you ask a patient when you're like, yeah, we know, compared to it might be, you know?
Yeah. So the most classic symptom is painful periods. And we're not talking like pop one Advil and then you're fine, good to go. We're talking about like the Advil's not touching it, missing school, missing work, unable to walk. It's pretty frequent for women to have pain so bad that they're passing out. So painful periods and enough that it's affecting your quality of life is number one. Number two is sometimes people will have pain with intercourse, and that's typically pain that's worse with deeper penetration because that's sort of high up near the cervix, which is where endometriosis likes to live. And then third is painful bowel movements. And the pain with intercourse and the painful bowel movements don't necessarily have to be with the cycle, but the period pain is usually in the few days before the cycle and the first few days of the cycle. So that's the most classic symptoms. And then people can have, bladder irritation, so they can have pain with urination. They can have pelvic pain outside of their period. And then sometimes women don't really have much pain, and their only symptom is infertility.
Oh, really? And they don't find out until they do an infertility test.
Yeah.
Wow.
Yeah. And it's just so variable. People can have endometriosis is graded on a 1 through 4 severity scale, and stage doesn't correspond to degree of pain, and it also doesn't really correspond to degree of infertility. So it's a confusing disease that we don't understand enough about.
Well, I was going to ask about that too, because you said Lily was a stage 2, right? Which is good because if I remember what you said correctly, it's been a whirlwind, but you had said that a stage 2, she's less likely for it to return.
Yep.
That's fantastic.
That was my next question.
Yeah.
What are the chances of coming back around the
Right.
second time,
Yeah, so I think that varies with the stages, right?
It does. So the endometrioma cysts on the ovaries, that's a type of endometriosis that's unfortunately fairly likely to come back if you don't suppress it with birth control pills afterwards. But peritoneal endometriosis doesn't seem to act quite like that. And it's really hard to study how often it comes back. In the literature, it ranges from 10% to 90% recurrence. And it's really just based on surgeon technique. What are they counting as a recurrence? Are they just counting recurrence of pain? Because to really know if there's a recurrence, they have to have another surgery, and not everybody's going to have another. So it's a very hard thing to study and measure.
Yeah, for sure. So what's the difference between, I know you do it a little bit, you incise it, correct? As compared
excise,
to
yeah.
Excise, thank you.
Yep.
I'm not a doctor.
Yeah.
What is exercise?
Okay, so endometriosis is when cells that are similar to the cells in the lining of the uterus are growing outside the uterus. And we don't know how they get there. There's lots of different theories, but my favorite new theory is maybe that people are just born with the cells in the wrong place.
Oh, really?
And the problem is that every month when the lining of the uterus sloughs off and a woman has a period, those endometriosis cells are bleeding too, but they're in the wrong space to come out the vagina. They're trapped in her belly. So it's basically internal bleeding. Blood in the belly can cause pain and irritation, and over time it can cause fibrosis, which is like a thickening or hardening of the tissue.
Right.
It can also cause adhesions, which means organs are stuck together when they should be kind of moving freely. And sometimes it lives in a cyst within the ovary called an endometrioma, which is the ovarian cyst, which would show up on imaging. But often it's just smaller spots, and they're really quite small, and so that's why it doesn't show up on scans. So when surgeons are operating laparoscopically and looking at endometriosis, there's kind of two main ways they can treat it. One is to excise it, which is to basically grab it and cut it out. And then we send that tissue off to the lab. They look underneath the microscope. That's the gold standard for diagnosing endometriosis. Surgeons can also just burn the spot. That's called ablation.
Right.
And for some people, that's better than nothing. But the problem with ablation is that often the endometriosis nodule is growing deeper than the surgeon is expecting. And so when you excise it, you can make sure you get the whole thing out, versus if you just burn it, you might just be treating the surface.
Right.
And then if there's any surrounding fibrosis, which is that thickening or hardening of the tissue around the endometriosis from all the inflammation, I remove that as well, which provides additional pain relief, versus surgeons who just burn it. That inflamed, hardened tissue around it obviously doesn't get removed and might even get worse because they're burning it.
Sure.
And then finally, when you excise it, you actually generate that little piece of tissue to send off to the lab so they can look at underneath the microscope. So for all those reasons, high-volume endometriosis surgeons always prefer excising it as opposed to ablating it.
Now, what would the reason be for not excising it? Is it just training, the ability to do so?
It's easier to ablate it. Yeah,
Okay.
It's faster.
So it's a solution
easier.
that they can provide.
Yeah.
But then why wouldn't they just refer them to someone like you? Or is there not enough of you?
There's not enough of me.
Okay.
That's one thing. And some of the big studies have shown that for early stage endometriosis, ablation versus excision is equivalent. But again, these things are really, really hard to study. And I think a lot of surgeons don't recognize that they think it's superficial endometriosis, so they think that burning it is going to be okay, but they don't have enough experience to know that it's actually going deeper.
Right.
So.
And is that just something that we could fix, say, in furthering education, or, I mean, or is that an actual fact? Do we know that right now, I guess, is the bigger question. Yeah.
I mean, it's complicated. I think a lot of OBGYNs did not train in a place that had a minimally invasive gynecologic surgeon like myself. And so they just don't really know, what's out there.
Okay.
And if you've trained in a place without sort of an expert surgeon, you see these surgeries being done, and sometimes they're just not really that effective, right? If they're
Sure.
ablating it and they're not really recognizing it all, they're not getting it all, then what they're seeing is these patients kind of not doing that great after surgery. And so then they're thinking, well, these surgeries don't even really work. It's just going to come back. And so I think that's why a lot of women, I think, just don't get offered surgery in the first place, because they're going to doctors who kind of think the surgery isn't a good treatment anyways. They don't really want to do it because they're not super comfortable doing it. And they wouldn't think to refer it if they don't know that in the hands of a skilled surgeon, it really can be very effective.
Sure. Yeah. Well, and I watched that, Lily and I watched that documentary that you recommended, Below the Belt.
Yep.
It's very interesting.
Yep.
I think it's the only one out there. If anyone listening to this cares, Below the Belt, who's the...
Shannon Cohen, and she co-produced it with Hillary Clinton. And Rosario Dawson.
Rosario Dawson,
Yep.
yeah. So actually, it's a really good documentary. What I found sad and interesting was the journey that those young ladies went through. I mean, I think Lily was very lucky, just by chance of us talking to someone that had it and referring us to you, and us kind of taking the shortcut to get with you. Whereas some of the young ladies in that documentary, they not only did they deal with it for years, but there was one girl on there that she was like 16, I think. And she was developing osteoporosis from the medication that they were giving her. Her bones were getting brittle at 16 years old.
Yep.
And finally, at the end of that, they had the surgery done, and they all felt much better. So it's just crazy to me that there's so many different things that they're trying to do to medicate it, I guess, to treat it, but they don't just jump to surgery. Is there a reason for that?
Well,
because none of the medications seem to help right now, right?
Yeah.
I mean, they stave it off a little bit.
Yeah. So my typical workup is, I start with an ultrasound. And if there's something structurally obvious, a structural obvious source of pain on the ultrasound, then often the first step is surgery. But if the ultrasound is normal,
Which Lily's was.
Yeah. Then, for some people going on hormonal birth control, just like a birth control pill or the patch or the ring or the IUD, for some people that is effective. And that's that's great. Sometimes people, though, will have mood side effects from birth control. I think that's a little bit underappreciated in the medical community.
Sure.
People could also have other side effects like decreased libido, weight gain, et cetera. So that's a consideration. And then sometimes women are actively trying to get pregnant, in which case they can't be on birth control. So for all those reasons, a lot of people do go on to have surgery. We do know if there's an endometrioma cyst on the ultrasound, medication is less likely to help with pain from that. And there's some concern that if you've never had the diagnosis of endometriosis and you're looking at an ultrasound and there's a cyst on the ovary, we can think it's endometriosis, but we never know for sure until we actually remove those cells and look at them underneath the microscope. So often those women have surgery also to just prove for sure what the cyst is. But yeah, so the hormonal birth control medications can be beneficial for some people, but not everybody.
Can they reverse endometriosis, or does it just kind of stop it?
The theory is that it suppresses it. So we would be essentially using birth control pills to try to stop her period. So if she's not bleeding out the vagina every month and she's not bleeding in her belly every month, then sometimes that will help with the pain. But we have seen endometriosis progress even on birth control. So we know it doesn't always suppress it.
Right.
And then the medication that the young woman was on in the film, she was on something called Lupron, which is a medication. It's a shot that works by putting you into temporary chemical menopause.
Now, is
and
that...
you can't stand it long term because it causes bone thinning. And as soon as you come off the medication, the endometriosis is it's still there. It's just not being suppressed anymore.
Is that a medication that's used for prostate issues for males?
Yes, also that.
Yeah, Michelle was on that when she was fighting endometriosis. Yeah. Anyways, go ahead. I'm sorry.
Yeah. So I mean, those medications that work by putting a young woman into menopause tend to have even worse side effects than.
So it's like a chemical induction of menopause.
Correct.
Wow. And is that permanent?
No.
Okay.
But you can't stand it long term because, as you saw in the film, she got the bone thinning and then she had to come off, and it's like, okay, well, now what's the plan? Are you gonna, keep a young woman in her 20s? You put her on one of these medications. Are you just gonna keep her in menopause until menopause? That's like 30 years. Like, what's the long term game plan here? So,
well, for a minimally invasive procedure, it's laparoscopic. I think Lil was with you for an hour, maybe.
Yep.
From when I left and she went back to when I got the call that she was out. I get that it's not like Hamp had his whole knee sawed off and a new one put in and pins and everything else. It's not as invasive as that. So it seems to me like it was a no-brainer after talking to you, because I know you did say, well, there are some medications we can try. And my immediate thing was like, well, if we're going to try these, but we know with some degree at least that the procedure is going to give her the best relief and the best, I guess, option towards healing from this, like, then it seems to me that would be a no-brainer. So I find it surprising that an OBGYN that maybe has diagnosed a patient with it doesn't just say, you need to go get this procedure done right away.
Yeah, I mean, I do think there's a role for trying medication. But yeah, not everyone wants to go that route. Sometimes people just want to know if they have it. They don't want to just mask it. They want to know why. And I hear that a lot.
And I'm probably comparing it to my daughter's experience, which she was in a lot of pain.
Yeah.
I mean, you'll never know what someone else's pain is, right?
Exactly.
I mean, I stood next to Hamp before he had his knee replaced, and he seemed like he was fine, but it was hurting him bad enough to go get his knee replaced.
Yeah.
So.
Yeah.
I'm like this. If OBGYN sees a cyst, why not just send them straight to you or to somebody in your field, I mean, so they can examine it a little bit more, Instead of just,
sometimes they do. Sometimes they do.
Just sending them away, say, oh, you'll be fine. No, you okay. Get it checked out,
Yeah. Yeah, well, especially because, for the cysts, and I know you removed a cyst from Lil, and that came back benign, which is great news.
Yep.
Is that pretty often that you see cysts accompanied with this condition?
Yeah. So the cyst that she had was not related to endometriosis, which was good. But yes, there's cysts that kind of hang off the fallopian tubes. We tend to see that more with people with endometriosis. I think it's probably related to inflammation. And then there's the actual cysts in the ovary. Most cysts in the ovary are just normal cysts that come and go with ovulation, but the endometrioma cysts on the ovaries kind of stick around long term, and that signifies more severe stage endometriosis. So we do see that quite a bit.
Is this hereditary? And because I asked because my wife, she recently passed away, but before we discovered that she had cancer and everything, she had fibroids removed from, I believe they were on the inside of her uterus, and she did have some ovarian cysts. They were benign that we knew of at the time. So if someone out there has a mother or grandmother that's had a procedure, are they more at a higher risk for something like this?
Yes. Well, first of all, I'm sorry to hear that.
Thank you.
Yes, if somebody has a first-degree relative with endometriosis, they have a 7 to 10-fold increased risk of having it themselves. So we know there's
7 to 10.
Yeah.
Wow.
So we know there's a strong genetic component. We just haven't like isolated the gene.
So my other two daughters, I have a 26-year-old and an 18-year-old.
Yeah.
They seem to be doing fine.
Great.
They have not had painful periods like Lily had. None of all the other weird side effects, which I kind of want to dig into as well. But for someone like them, being the age that they are without these issues, should they be fine, or is it something that could still pop up later in life?
It could pop up later in life. A lot of endometriosis patients tell me that their periods have been painful ever since they started. But sometimes that's not true. Sometimes they just get worse over time. Sometimes after having kids, periods will get better, but sometimes they'll get worse. So it can be really variable.
Okay. So for someone like my other daughters that haven't had an issue, but they have had their sister now that has endometriosis, they've had their mother that's had fibroids, would it be smart for them or myself as a father to say, hey, you should have like a fertility check done before you get pregnant? Because pregnancy can be dangerous, right? If you have these conditions, or am I wrong?
I don't know. They can cause trouble. Both fibroids and endometriosis can cause trouble getting pregnant. Once people are pregnant, there might also be a slight increase in the risk of miscarriage, but not necessarily dangerous to the mother, maybe a little higher risk in the pregnancy. So, yeah, I mean, really, whether or not somebody needs to be checked out should be based on their symptoms.
Okay.
But if you have a first-degree relative with one of those diagnoses, then you just want to have a really low threshold in the future. If they start having new symptoms like heavy or irregular bleeding or pain, or if they're having trouble getting pregnant, then I would just have a lower threshold to, start the workup. Yeah,
that makes sense.
Yeah.
So a lot of pain and heavy bleeding are the top two symptoms that you would say you would look into?
Yeah. Heavy or irregular bleeding and then pain. Yep.
Hamp, your daughter kind of went through some of that stuff too, right?
Yeah, years ago. Yeah, she couldn't stop bleeding. She was. I forgot what she had. I don't know if it was an MCO, something like that. I don't forget. It sounded like a state, but she was bleeding constantly. She had a period and she was just constantly bleeding. And I don't know what they did, but they ended up.
She had a procedure done though?
No, she just had babies.
Well, see, and I've heard. So a guy that I work with said that his wife had endometriosis, and then after they had their sons, it went away.
Yeah. So there's sort of a myth out there that pregnancy cures endometriosis, but in reality, after having kids, some people's symptoms get better, some people's get worse, some people stay the same. So for some people, it does help, but not for
it
everybody.
might have helped her because she had a set of twins and 4 after that.
She's got a lot of kids. She's definitely not infertile.
Basketball team and a setup.
Back to the fertility question. The typical recommendation is, if people are trying to get pregnant, try for a year. 80% of couples will be pregnant at the end of the year. And then if you're not pregnant after a year, then that's the time to reach out to a fertility specialist.
Okay.
If you're older, if you're like 35 or older, maybe don't wait a whole year, maybe 6 months. But if you're having symptoms, irregular cycles, painful periods, irregular bleeding, heavy bleeding, then it would make sense to, reach out sooner.
Gotcha. Okay. I want to dig a little bit into the symptoms because Lil had some crazy symptoms, and I did want her to try to join us today. She's not quite there yet, but we're gonna do a follow up with her once she's feeling good too. So some of the things that we read and some of the things that I noticed in my daughter ranged everywhere from headaches to food allergies to constipation to hives on the skin. I mean, there are so many symptoms out there that are correlated to, could possibly be part of endometriosis.
Yeah.
I mean, Lily never had a food allergy. She never had a food allergy. And now, like, one day she couldn't eat an apple, and the next day it was like sesame seeds, like random stuff.
Catfish.
Yeah, she liked Ham's catfish, and then all of a sudden she couldn't eat. I don't know if it was the seasoning that he puts on it or what it was, but she couldn't eat that. Like, so are those common things that you see, or is it different for everyone?
Yeah, I mean, the GI symptoms, I think, are the ones that people tend to sort of go down the wrong path with the
Which
most
we definitely
often.
did.
Because, a lot of my patients have had colonoscopies, they've had upper endoscopies, they've seen, they've been diagnosed with IBS, irritable bowel syndrome.
That's actually in her medical chart, and she's like, no one told her that, but it's in her chart.
Oh, there you go. Great communication.
Yeah, exactly.
So Alternating constipation diarrhea around the time of the cycle is very common, but some people will really just be like predominantly constipation or predominantly diarrhea. Painful bowel movements, some people have that. And then just bloating and food intolerances. We hear that a lot too.
Do those tend to go away after a procedure?
That's the goal. I mean, I think it just has to do with inflammation in the belly, just kind of probably slows down the gut.
Right.
Is my theory, but I don't think anyone really knows.
Right. There's just so much that we don't know about. It's crazy.
Yeah.
For 1 in 10, right?
Yeah.
That's the stat. 1 in 10 women to have it, and so much that we don't know.
Yeah, because she changed in weight just like that.
Oh yeah, she did big time.
I mean, she was like this, then she was like this.
She did gain a lot of weight, a lot of bloating.
It's hard to take care of yourself when you feel horrible all the time.
And that's it too, you know. I mean, she used to love to go hiking and all these things, and pretty soon it was just if she could get through the first half of the day, if she woke up good, you know, and made it till 2-3 o'clock before she crashed, that was a good day, you know. So I'm excited to see her come out of this and feel a lot better.
Me too.
Very excited. So you removed, correct me if I'm wrong, 8 areas that you saw in Lil and 7 tested positive for endometriosis. Is that correct? I don't know if you remember off the top of your head. You have more than one patient.
I'd have to look at her chart, but that sounds like, yes, that sounds right.
That's what I remember. On a scale from least to or best to worst, like scenario, where does she sit with that many locations in her? Is that kind of standard? I mean, I guess what's the worst one that you've done?
Well, so stage 4 endometriosis, typically women have endometrioma cysts on both ovaries, and they're stuck to the side of the pelvis, stuck to the back of the uterus, stuck to the rectum.
Wow. So nothing's moving, nothing's working the way it should.
It's sort of like a cement block down in the pelvis. And then there's often additional spots of endometriosis in other places. So, I mean, those surgeries can take up to 6, 7, 8 hours. That would be very rare. But it's just one of those things, like stage doesn't correspond to degree of pain, and it doesn't really make a lot of sense. But I heard a good analogy that I liked the other day. If you have a hot coal in your shoe, it doesn't matter how big it is. Even if it's small, it's still going to hurt like hell, right? So, it's.
What's the longest surgery that you've had to do?
I think like 6 or 7 hours.
That sounds exhausting.
It is.
Yeah. Well, you're doing a good thing. I mean, I was so happy when we found you. And I'll tell you, I was happy when we found out that she had endometriosis during the surgery, if that makes sense. Because there was still, you know, like you said, you can't test for it. So there was a small piece in her and my mind going into it that you were going to go in there and then come out and go, no, she's fine. Because that's what every doctor had told us up to meeting you. You know?
Yeah, I mean, that's everybody's biggest fear. Like, I'm worried you're not going to find anything. And, you know, when I take people to the operating room and they have this sort of classic constellation of symptoms, I almost always find something.
Yeah.
But I saw a patient the other day, and she said she'd seen another doctor who was like, oh, everybody thinks they have endometriosis, and I almost never find it. Well, that to me says that doctor wasn't trained to look for the more subtle atypical lesions.
Right.
So sometimes endometriosis is obvious, like a dark brown or a black spot, but sometimes it's really subtle, like a little clear droplet, a little red droplet, a little white area, a little area that's just thickened or less flexible, or even just like a subtle dimple or puckering in the tissue. And most OBGYNs are not trained to recognize that could be endometriosis. But we find when we take all that subtle stuff out, a lot of it does come back positive. And it's more common for it to be that atypical appearance in younger patients, because I think the theory is that as those lesions cycle with each menstrual cycle, over time they become that dark brown or black color. But initially, when they're younger, they start off being more subtle.
That makes sense.
So
it's an imperfection, something that doesn't look like it should be there. I mean, yeah. So did you learn that just through multiple surgeries, or was that part of your training in the beginning to look for things like that, the subtle things that everyone passes up?
I learned some of it in my fellowship.
Okay.
But also, you know, I've been just learning a lot. I've been in practice for 10 years, and I'm recognizing endometriosis lesions now that I know I wasn't detecting, you know, even 5 or 6 years ago.
And you're removing those and having them tested so you know.
Yes.
Right.
Yep.
Right.
And then when you separate out those tissue specimens instead of setting them all together, then you can look back and be like, okay, I was right about that one. That one maybe wasn't. And it can be a little tricky because sometimes if the pathology comes back negative, that just means the tissue was damaged during the removal process.
Right.
But sometimes it probably means it actually is negative. So, I just have a low threshold if something looks unusual. I remove it. And the longer you do this, the better you get at it.
Sure.
And the more little subtle stuff you start seeing.
Yeah. No, and that makes sense. And the thing too is like I said, it's minimally invasive. So if you're just removing a small piece of tissue on the inside, it's going to heal, right?
Yep.
As long as you're not on a bowel where you can't do it or somewhere like that.
Exactly. The lining of the pelvis and the abdomen is called the peritoneum. It's kind of like a thin saran wrap lining. And that's usually where the endometriosis is living. And that will just re-peritonealize, which means that sort of film just grows back relatively soon, like within 24 hours. And that'll just be soft, healthy tissue as opposed to that sort of inflamed, fibrotic,
Right.
inflammatory tissue that was there.
Right. Yeah. So why not give them a chance to just heal and have the good stuff there,
Yeah.
right?
Yeah.
No, that makes
And
sense.
I kind of like what you were saying about like, yes, it's a surgery, but it's laparoscopic, it's outpatient. And I think that all the time too. I'm like, a lot of patients tell me their recovery pain was not even as bad as their period pain.
Right.
So like, is going to surgery that big of a deal when you're, missing a week of work or school every month? Like, isn't
Right.
that a bigger deal
Yeah,
than an
for sure.
outpatient laparoscopic surgery? And not to minimize it, but like,
No, I agree with you
yeah,
100%.
I think that there's sort of a fear of surgery, which is understandable, both with the doctors and with the patients. And yeah,
I'm not a big fan of medications. I'm not a big fan of having to be on anything for an extended amount of time because there's always side effects. I mean, we're one of, I believe, 2 countries in the world where we can have these medical medications like advertised on TV. When you see those.
yeah, the direct-to-consumer advertising.
Exactly.
That wasn't a thing when I was a kid. I remember when that changed,
Right.
and yeah, I don't like it.
And there's necessary ones out there. I get it. But with every one that you take,
Yeah.
there's a medication for the side effects of that medication, you know? So I've always been, with my kids, with my family, if you need it, okay, then we're going to do it. But let's try to take a path that you're not on this thing forever. Even birth control. Like I know my girls are actually both of them are on it except Zoe's 18 and she swears she's not doing anything. And I told her, I'm your dad. I know it's weird, but you got to tell me because you got to get on this unless you want.
We need to put all state around you, okay?
Yeah,
Yes.
I mean, for some people, birth control pills have side effects, but for a lot of people, they don't. And
Right.
if you're having sex and not on birth control, then you get pregnant. That's a pretty dramatic side effect.
That is a
of
dramatic
not
side
being on the
effect, yes.
medication.
Yeah,
So
that's
Had
serious
those
side
conversations.
yeah, and birth control pills are safe long term. They actually decrease the risk of uterine cancer and ovarian cancer long term.
Oh, really? I didn't know that.
Yeah, they may or may not suppress endometriosis. The studies are kind of mixed there. So I'm not anti birth control. I think it's great for a lot of people, but it just doesn't work for everyone. And so surgery needs to be an option as well. And when I see patients in the office, I take a full history, listen to all their symptoms. And then, teach them about what I think they have, either fibroids, which have shown up on the ultrasound, or endometriosis, which usually doesn't show up. And then I lay out all the options, right? Do nothing, take ibuprofen, take, some type of hormonal birth control. There's the medications that work by putting you into menopause, but you can't stay on them forever. And then there's the surgery options, and there's a couple of different surgery options. And I just kind of lay it all out on the table.
Sure.
And, let patients choose.
I know that Lily thought there were 2 times that we took her to the ER because she was in so much pain.
Yeah.
She was doubling over. She was vomiting.
Yep.
She was near blacking out.
Yep.
Both times they said that they think it was a kidney stone, but they never found a stone. And I'm pretty sure it was endometriosis, and that happened, I think, the first time when she was like 13 or 14,
Yep.
but nobody, we just didn't know. And
Yep.
like you said, missing days of school,
Yep.
she couldn't even get out of bed some days and all the doctors that we went through and all the things. But so if a woman is experiencing these things, what would your first step be? Go to the OBGYN, talk to them? Because like for us, talking to our primary care, Dr. Parker, she was great, female doctor. She never brought it up to us. She's moved, so she's not our primary care anymore. We saw a gastroenterologist. We saw a nutritionist. I can't even remember all the doctors we've seen, but many doctors, many medical bills, and not one person brought it up. So, and the OBGYN, no one ever brought it up. So is it just to self-advocate for yourself? Is that the way to do it? Is that the only way to do it right now?
Yeah, I mean, most people would start with their OBGYN, but if you feel like you're not being heard, or if even if they are offering a surgery, if you talk to them about how often they do this, what their experience is, and you don't feel comfortable with that, you can always go straight to a specialist. You don't need a referral to see a minimally invasive gynecologic surgeon.
Right.
So if you have an OBGYN, you trust, you feel like you're getting good care there, you're making progress, that's great. But if you don't already have a general OBGYN, there's really no reason not to just go straight to a specialist.
Sure. How many specialists are in our area, like you, in the Seattle area?
There's a handful of fellowship-trained minimally invasive gynecologic surgeons here in Seattle.
Okay. I know your name came up, you were referred, so we went straight to you. There was another lady that was out of Oregon, I believe, that was brought up. I don't remember her name. But we didn't do any more research really once you were referred, so I wasn't sure how many actually do what you do.
Yeah. Yeah, I mean, and it's...
Hey guys, it's Joe with Stick Lounge Podcast. Just wanted to do a quick check-in with you all. Say thank you so much for trafficking the socials and liking all of the shorts. We got a lot of those that are doing pretty well right now. But what I would like to do is to say, because we don't say it enough, like, share, and subscribe. And please do that. And leave a comment too. You know, if you see something that you have an opinion on or anything, leave a comment, check it out. I'd really like to see some more traffic to the YouTube stuff, to the Spotify, the iTunes, the iHeartRadio, all of that. We work really hard on this. I spend a lot of time putting these things together, all of our own time, all of our own dime. So like to see some more traffic there, guys. If you can help us out, really appreciate it. Hopefully you're enjoying the show. Lots of local businesses, local people, local politicians, really covering what's going on in our neck of the woods, in our own backyard. So I've learned a lot. I hope you are too. Stick Lounge Podcast, guys. Hang with us. Like, share, and subscribe. Thanks.
Yeah, I mean, and there's gradations, right? Because OBGYNs also do these surgeries. So it's really hard to... it's hard for patients to know what the skill level of their surgeon is. So that's why, asking for referrals, looking online, interviewing. A lot of times people will see multiple doctors and just kind of decide based on the conversation who they feel comfortable with. So there's a lot of ways to go about that.
Now, I don't think you saw Amara's interview, did you, with us?
No.
Okay. So Amara had a lot of problems, issues like my daughter did for years and years. Finally ended up in the hospital septic. And if I remember correct, Hamp, her and her mother were telling us that the doctor was telling her parents to prepare for her to pass. Is that right?
Yeah.
It was very hard on them, very emotional, because they didn't think she was going to survive. Yeah. They didn't know why. And I want to say, and I could be getting this wrong, that a nurse was the one saying, like, she has endometriosis, like, we need to go in and do this surgery. I believe she had the ablation done. But how many patients have you seen get to that severe of a situation before something is done or explored or whatever?
Yeah, I mean, I don't know her case and what happened, but to me that sounds like potentially she had like maybe a partial bowel obstruction. Sometimes endometriosis can be in the appendix, and that can cause a bowel obstruction. So I've had several patients with endometriosis in their bowel. One of them was so obstructed that they kept throwing up, and then they aspirated. So then they had like an aspiration pneumonia from throwing up. And she turned out to have a big endometriosis nodule in her appendix in the first part of her colon that was almost completely obstructed. So that is one of the rare situations where endometriosis can actually be like really dangerous and life-threatening. Usually it's, debilitating pain, but it usually won't kill you, which is one of the reasons I think it's been hard to get funding and hard to get people to take it seriously, is that it kind of acts like cancer, right? It spreads and it causes horrible pain, but it usually doesn't kill you. But I think people don't really appreciate like how debilitated these patients are. The pain is, we need to pay attention to this, even if it's not cancer.
She was good and bloated. That's the most way I hear.
Yeah. Yep.
Yeah. Amara and Lily
endobelly.
Both. Yeah. Endobelly. Amara had pictures. I mean, she was 14, I think, in the picture, and she looked like she was a couple months pregnant, and Lil, I mean, she's wearing before the procedure, she was wearing maternity pants sometimes because it's the only thing that was comfortable enough for her to wear. So
bloating, a very, very common symptom.
Yeah. How many cases do you know of where someone has actually passed away from this? Is it very rare?
None personally.
Okay. Well, that's a good thing. That's a good thing. I mean, it sounds like Amara was close, and it sounds like if it happens, it's not directly the endometriosis, but something that it's affecting. Is that safe to say?
Yeah.
Okay.
Or potentially a complication of surgery. Knock on wood, I haven't had anyone die.
We'll give it.
Yeah. Thank you.
So in doing the research that we did, we found that it has been found in women's lungs, in women's brains.
Yeah.
Now, is that super uncommon?
Pretty uncommmen.
Okay.
So
but it can spread that far.
Yeah. And again, we don't know if it's really spreading or maybe it was
just was there.
When the when a woman's like developing as an embryo, the reproductive tract is 2 hollow tubes, and then they merge to form the uterus and the ovaries. And sometimes with all of those parts moving around, the merger cannot go properly. And so sometimes people will wind up with a septum, which is like a dividing band in the uterus. So there's just a lot of things moving around during the development in the embryo. And I think it's easy to imagine how some of those cells might migrate to the wrong place.
Right.
So that's the embryologic origin theory. That's personally what I think happens. But again, nobody really knows. But the lung endometriosis, the classic symptoms there would be catamenial pneumothorax, which is when your lung collapses every month with your period. That's dramatic.
Whoa,
so you have to
really?
go to the ER, get a chest tube to reinflate your lung.
Holy cow.
Or if you're coughing up blood every month with your period. So those are pretty dramatic symptoms. But a lot of times people will have chest pain from endometriosis on their diaphragm, so it actually isn't in their chest, but it's causing chest pain. So that's why we always look up high during the endometriosis surgeries to see if there's any endometriosis up high on the diaphragm, typically above the liver.
And then if you find that, then you kind of continue.
Remove that as well, yeah.
Okay, gotcha.
We can't, as a gynecologic surgeons, we're not trained to operate in the chest.
Right.
So if there is endometriosis in the chest, which is crossing to the other side of the diaphragm, that involves coordination with a cardiothoracic surgeon.
Have you had to do that before?
I've done some of those cases in my fellowship.
Really?
Yep.
That's crazy.
Yeah.
That's wild. So I know we're working together with Senator Tina Orwell. What would you like to see come out of the legislation that we're trying to push forward? I mean, I know we're in the very early stages. We just had a talk about what basically this is going to be. And you kind of talked about in the meeting, you know, what you'd like to see. But just for everyone here that's going to see this, what would you like to see done and you know, help awareness, help further education? Like, how would we go about that?
Yeah, you know, I talked to the director of Below the Belt, Shannon Cohen, when I was getting the links so we could all watch the documentary, because otherwise you have to go to one of the like private screenings to see it.
We actually paid for, we found a website and paid for it and watched it. And then like 2 days later, you sent the link.
Oh, really? Because that's interesting, because when I wanted to watch it, I actually couldn't find a way to do it, even paying for it. So you'll have to.
Lily found it.
You'll
I'll
have
have
to
her
send me
send you the
that,
link. Yeah.
So anyway, so I was talking to Shannon, and you know, I said, you know, I'm meeting with a senator. Like, I'm not really used to thinking about policy issues. Like, what can we do from a policy perspective, in your opinion? And she has developed what started off as a school nurse toolkit, which is like a informational, educational program for school nurses, so they can recognize that that's what might be going on if these girls are winding up in their, you know, nurse's office every month. But they've sort of expanded it to just a frontline provider toolkit. And so she was like, yeah, I mean, if we could get this toolkit into the hands of every primary care doctor, ER doctor, and school nurse and pediatrician, like that would be huge.
Okay.
So I think that's kind of what Senator Orwell was thinking as well. She was like, you know, we could make some training requirements as doctors get their recertification every year. You know, they could be required to learn about endometriosis. So I think that would be a great first step.
Now, and I'm not trying to throw shade on any physicians or anything like that, or doctors at all. I mean, I appreciate everything they do. We've had some mishaps within my family with some doctors, but I understand that everyone is doing the best they can do.
Yep.
But do doctors typically, I'm sure it depends on the person, but do they look at that further education stuff and really pay attention to it? Or do you feel like there might be there's a requirement, I got to watch this video? Because honestly, I'm in the construction space, which is nowhere near as important as what you're doing. But
That's not true.
well, I have a lot of things that I have to stay up on, right? Like OSHA 30s and, you know, all these different safety things.
Yeah.
And I'll be honest, when I get these videos and I got to watch them to keep a certification, I probably put them on, watch them a little bit and do some other work while I'm, you know what I mean? So is that something that you could see happening, or?
Gosh, that's so, you know, provider dependent.
Sure.
But, yeah.
That's a tough one.
I don't even know how to answer that question. Some people will pay attention and some won't, right?
Sure.
But if you could reach, you know, even a few more people, that's better than none.
Yeah, for sure.
Yeah.
Totally. Yeah. And I think early detection is good too.
Yeah.
You know, I think if Lily would have had a school nurse that told me and her mother, like, hey, we think your daughter has this at an early age, we wouldn't have made it till she was 20 years old to have this procedure, you know? So
I think the part of the problem with sort of informational, educational, continuing like CME type activities is that they can be very, you know, cut and dry. And you do want the scientific literature in, you know, you need to look at the evidence if you're a doctor. But the documentary, Shannon talks about changing hearts and minds, right? So hearing the personal testimonials of these women is really what makes things stick with you.
Right.
Even as a medical professional, when we're trained to just look at the studies, look at the facts, look at the numbers, if you don't have some personal connection, it's very hard to retain that or care about that.
Yeah.
So for me, I just hear so many women in my office every day, with these stories of so many years of pain, so many doctors, nobody listening to them. That I've Kleenex in every exam room because, like, I would say half the patients start crying
Yeah,
when
sure.
I'm like, oh yeah, well, this sounds like classic endometriosis, and they're
I
like,
think I teared up when we
yeah. So it's
Let's
just
talk about my daughter, man. Of
Yeah.
course I teared up.
yeah. So it's just hearing directly from patients' stories is so powerful.
Yeah. Yeah. And I actually, there's a woman that I spoke to. She's going to be part of the next meeting, which is tomorrow. She sent me a long text message about her battle. Matter of fact, give me 1 second. She was introduced to me from Michelle, Salon Michelle. And let's see here. So she said, hi, Joe. Thank you for reaching out. Yes, I would like that. I asked if she'd be a part of giving her testimonial. Mm-hmm. She said, I've suffered with this disease for most of my life. After many years of gaslighting from doctors, I was able to find the right doctor and treatments to help me feel better. I had to be my own doctor and learn how to advocate for myself. I am making it my mission to share my story so others don't have to go through what I had to go through. Yep. And that's only, after we put the podcast out with Amara, there was a lady that reached out and commented on one of the YouTube videos that she never knew she had endometriosis until she had a hysterectomy at the age of 50. She was just in pain the entire time trying to deal with it,
Yep.
And those are the things that passed. Luckily, finding out what was going on with my daughter, I'm like, this is crazy how many women are going through this.
Yeah.
And then my mother-in-law came to visit. She was here for Lily's surgery. The lady on the plane she sat next to had endometriosis.
Yeah.
And that lady knew like 3 or 4 other ladies that had endometriosis. So it's just crazy.
I think the awareness is improving, and I think people are a little bit more willing to talk about this stuff in the news and in the media now. Like, before, it was like, oh, periods, bleeding, yuck, right? And like even menopause, people are starting to feel more
I'm the
comfortable
only man in my
talking
house. I'm very comfortable with it.
Yeah. So, yeah. You mentioned hysterectomy. An important point for listeners out there is that, endometriosis is by definition outside the uterus. And so there's kind of a myth out there that a hysterectomy will cure endometriosis, which is absolutely not the case. But women who have endometriosis are more likely to also have an adenomyosis or adenomyosis, which is kind of like endometriosis embedded in the muscular wall of the uterus. Sometimes that'll show up on imaging, but sometimes it's not detected until after the hysterectomy when they're looking at the uterus underneath the microscope.
Wow.
And then even in women who don't have adenomyosis, there just seems to be something about the inflammation from endometriosis that does make the uterus and the cervix more tender. So if a woman is done having kids or not interested in being pregnant in the future, then adding a hysterectomy to the excision of endometriosis can be beneficial. But it's just important for everybody to know that a hysterectomy by itself, without excision of the endometriosis, is not a cure for endometriosis. And yeah, even if you excise the endometriosis, it's still not a cure. Endometriosis can recur.
You must be reading my mind, because that was my next question.
Yeah.
Having a hysterectomy would take everything out.
Yeah.
You won't have no problem.
The other sort of misperception out there is that a hysterectomy also involves removing the ovaries, and so a hysterectomy puts women into menopause, which is not true.
Oh.
Hysterectomy is just
I
removal.
thought that as well.
Yeah.
I did.
Yes. Hysterectomy is just removal of the uterus. The ovaries, which produce all the hormones, if those are normal, those can be left in place. So a hysterectomy does not mean a woman goes through menopause, but it does mean she never has another period. If she has fibroids or adenomyosis, those can't come back. And if she has endometriosis, if she has a hysterectomy with excision of the endometriosis, she's less likely to need another surgery down the
What about
road.
hot flashes? Let's go there.
That's related to menopause and the ovaries.
Right.
So if the ovaries are significantly involved in the endometriosis with endometrioma cysts on them, then often we will remove the ovaries as well. Because if we just take out the cyst and leave the ovary in place, that puts them at a pretty high risk of endometriosis coming back, especially if they don't want to go on birth control pills afterwards. Gotcha. So sometimes we do take out the ovaries, but only if they're significantly involved in the endometriosis. If they're normal, we leave those in place. And then, she would go through menopause roughly when she would have, the average age of menopause is 50, 51. And so that's where the hot flashes and the night sweats start to come in.
It's where Hamp sleeps under
my
ice.
wife. My wife.
Perimenopause, menopause. And hormone replacement therapy is actually very effective for that. So if she's suffering with that, there are options, and there's people who actually specialize in menopause. So there's things we can do for that.
Oh, yeah, that's good to know. Well, I'm going to wait till this winter pass. Okay, I use it as a heater.
I've seen pictures of Hamp with a beanie on his head and 6 blankets.
And she's got the air conditioner on, and I'm freezing to death.
the struggle is real.
Yeah, yeah. For sure.
It sure is. I'm
So
a living
it's-
testimony.
So a hysterectomy then in the sense, and I didn't know this, is similar, I mean, much more invasive, but to a vasectomy, which I had. Because they didn't take anything. I'm still getting my hormones and everything that I need.
Yep.
Same if you're able to take the uterus and leave the ovaries in place.
A better analogy for a vasectomy is a tubal ligation.
Okay.
So that's just permanent sterilization. We used to like clip or tie the tubes, and now we just actually remove the entire
I
fallopian
think they
tube
cut like for me, they cut a section out for the
the vasectomy.
Yeah.
Yeah. So that's the analogy.
No reversal.
I got no reversal.
Yeah. There's really
I'm
no
done.
good analogy to a hysterectomy for a male.
Okay,
So,
gotcha.
yeah.
I just meant that you're still going to get the estrogen and everything that you need.
That
Okay.
in that sense, that is correct. That is similar.
Gotcha. Yeah, boy, we got into some places on this podcast I didn't know we'd ever get into, bro.
Yeah, I like to learn new stuff.
We're learning all kinds of stuff. And this is a big one to come back from our break. We took like a month off, and now here we are.
Go home and tell my wife, surprise.
So what do you want to get out there for people? I mean, it's been great working with you. Actually, before we get there, I do want you to share your stuff, but I want to talk a little bit about funding for you. As far as like you can't collect from insurance or anything. I know we paid you out of pocket, and I will say right now for everyone, your price is very fair. And I appreciate that. When we talked to you, it wasn't something where I'm like, I'll never be able to afford this. You know, like it was doable, which is great.
Yeah.
But because you're a specialist, we can't, most insurances aren't going to pay for it. Is that correct?
Yeah. I mean, it is very hard to maintain a private practice if you take insurance because reimbursement for women's health is low. Reimbursement for gynecologic surgery is lower than all of the other surgical subspecialties. And so all of the private practice groups in town are going out of business.
Oh, really?
And either being bought by hospitals. So it's basically like doctors are going to essentially either work for a hospital, a university, or if they want to be private and own their own practice, it's very hard to do that without going out of network.
Wow.
Which is something that I didn't want to do, but I figured if I opened a practice and it just went out of business, then I'm not helping anyone either.
No, that makes sense.
So yeah.
It does.
So yeah.
So is it better for you then as a business to be out of network?
Yeah, because
Okay.
then you're not beholden to insurance companies, and they basically can pay whatever they want. And
Okay. I got you.
it requires also a lot of staff to kind of like fight with the insurance companies to get them to pay you.
Yeah.
And so so it kind of simplifies things as well. But if patients have out-of-network benefits, they might be able to get paid back for a portion of the surgeon fee. And we do partner with Care Credit, which offers like interest-free loans. So we've tried to go out of our way to, make the system as least cumbersome for the patients as possible.
Sure. I mean, it sounds like it's working for you, which is good.
Yeah.
I mean, my question just really comes from like people that might not have, the ability to pay out of pocket and they need to go through their insurance or something. I mean, at that point, you're probably going through your OBGYN and not you.
Yeah. I mean, there are endometriosis surgeons that take insurance. I was employed by the hospital for about 7 years, and I was taking insurance. I, at that point, was booked out for like 9 months to get in to see me, and then like booked out another 9 months for surgery. At one point, I had 100 patients scheduled
Wow.
and waiting for surgery.
That's for just endometriosis.
For fibroids and endometriosis, yeah.
Wow.
And, they were, of course, in pain or bleeding, because if I could solve that without surgery, I would have. But, so then it was unmanageable. I mean, it was
That's
such
crazy.
a huge patient load.
Yeah.
So one of the benefits with out-of-network care is that, our appointments are longer. I see fewer patients in a day, and so I can really take the time I need to do the teaching, explain to them, and give them a little bit more personalized attention. And then the other thing I was able to do in setting up the private practice is create a multidisciplinary team, which includes a dietitian who focuses on endometriosis, an acupuncturist who's been doing women's health and fertility-focused acupuncture for a long time,
Oh, wow.
a pelvic floor physical therapist, and a mental health specialist.
Okay.
Because a lot of times patients have other needs in addition to just surgery, right?
Yeah.
And so that would have been very hard to create in a big hospital system.
yeah,
but
for
when
sure.
you're a small independent practice, you're very nimble, right? So I could just recruit those people. They see patients in my office, and we're one of the first actually multidisciplinary teams in the country. So that's very
congratulations.
yeah, thanks. It's
very
it's
cool.
exciting, and it's a model that I hope that other places can replicate.
Yeah, definitely.
Yeah.
No, that sounds like it's working great for you. I was more thinking that it was more difficult for you not being able to, for being out of network, but it sounds like it's working out great. So that's fantastic.
Yeah, it's going well.
So when you did Lily's procedure, how many patients did you see that, or how many surgeries did you have that day?
I usually do 2 to 3 surgeries in a day, occasionally 4, kind of depending on how long they are.
And how many days a week, or how many times a month?
I'm operating about 2 full days a week.
2 full days a week.
Yeah.
So you're removing endometriosis from that many women right now.
Yep.
That's crazy.
I'm coming up on my 1,000th surgery at Swedish.
No
and
kidding.
then I was in practice in St. Louis, Missouri for roughly the same amount of time. So I probably did about 1,000 cases there. So my estimate is I'm coming up on 2,000 cases. Yeah.
That's crazy.
Yeah.
Wow. Well, congratulations. But I mean, that's just crazy that there's that many women out there having this procedure done, and we're still so far behind on figuring out better ways to, diagnose it, treat it, or just have someone mention it to you in a freaking appointment that you, one of the many appointments, your nutrition looks good, your gastro, everything looks good. You might want to look into this. That would have been great. I would have appreciated that.
It's like lack of funding, lack of research, lack of knowledge from the providers. It's, the patriarchy, not believing women. It's so many factors.
Well,
it's so hard. It's such a hard problem to fix because there's so many things wrong.
Well, and I'll be honest. I mean, I'm a dad of 3 daughters, right? And when Lily's periods were painful, I didn't know, and my wife and everyone's like, some women just have really painful periods. Like, that's how it is. So the questions for me stopped there.
I mean, that's true. Some women do have really painful periods, and there's something we can do about it.
Right. Yeah, that's crazy.
You got some Advil.
Yeah, that stuff, I don't know, man. It does help my younger daughter for sure, but no, it didn't work for Lil. I know that this is probably a stupid question, but I'm going to ask it anyways. Do you know of any way that we could detect this better? I mean, we've got PT scans, PET scans, we've got CT scans, we've got, ultrasounds, we've got all this technology.
Yep.
And correct me if I'm wrong, but this is a tissue on a tissue. So it's going to be really hard to see, but there's nothing that we can do out there to do a better job for scanning for this or look, other than symptoms.
Yeah. So with an ultrasound, a generic pelvic ultrasound will just sort of measure the size and shape of the uterus and the ovaries, but there's something called a dynamic ultrasound where they're not only just measuring the uterus and the ovaries, but they're also pressing on them with the transvaginal probe, which is how they're scanning, to see if the uterus moves freely against the rectum or if it seems like it's stuck. If it seems like the uterus is stuck to the rectum, that's very highly predictive of advanced stage endometriosis.
Okay.
Or if the ovaries seem like they're stuck to the uterus, et cetera. So there are poorer quality ultrasounds and better quality ultrasounds. And if you're at a center with a high volume endometriosis surgeon, they're going to have access to radiologists who do these specialized endometriosis scans, which are much, much better. So that's one sort of specialized ultrasound. And then there's an MRI.
Can you request that?
Well,
or a doctor can for you? Or
not every radiology center knows how to do it.
Okay.
So you have to be at a center where the people scanning know how to do it, or the doctor is doing it themselves.
Gotcha.
So when I moved to Seattle, 7 years ago now, I brought the second modality is an MRI. So an MRI is kind of like a CT scan, but it's better at looking at soft tissues like the uterus and ovaries. And an MRI will pick up some bigger nodules of endometriosis, but it still won't pick up the really small spots.
Okay.
So Lily's MRI probably would have been negative as well. But for some people, the ultrasound is negative, but the MRI is positive. So it's a tool. I mostly use it to predict if the endometriosis is invading into surrounding organ like the rectum or the bladder, and if we're going to need to coordinate with a colorectal surgeon or urologist. So that's how I use MRI. But it can also be negative when the patient still has endometriosis. Right. So how do we detect it? Yeah, I mean, maybe some sort of molecular genetic test or
that's a good idea.
A protein test. They're looking at maybe there's markers actually in the menstrual blood. Maybe we could test the menstrual blood, although the menstrual blood is coming from the endometrium, which is the lining of the uterus. The endometriosis is out in the belly.
Really, yeah.
So there's no good way to access that.
Yeah.
We need some basic science researchers on this.
And is there anyone out there looking into that? I mean, we're constantly looking at, Parkinson's and Alzheimer's and cancer and all these things.
People are looking at blood tests and testing the menstrual blood. Like I mentioned, those are the two that I've heard about. And in my mind, I guess that would be useful. But for me, I don't really need a test like that, right? Like I can just talk to a patient and be fairly confident that
you were very confident when we talked to you.
I would rather
more confident than I was.
I would rather see those dollars in research going into better treatment.
Okay.
Because I don't think surgery is the ultimate answer. I think that if we had like a vaccine or some sort of immunotherapy for endometriosis, I mean, maybe the surgery still needs to be done in conjunction with that, kind of like how we treat cancer, right? You get the surgery and they get chemo afterwards. If there was something like that, I think that makes the most sense. But I do think a diagnostic test could be useful because even though I don't need it, I can just talk to someone and be, pretty sure if they have it or not. Maybe that would help the primary care doctors or the OBGYNs who are not as experienced.
Tick some boxes and
maybe that would just prompt more referrals to the surgical specialists. So
that makes sense.
Yeah.
I think there's a lot more that needs to be found out in general because I mean, if you're correct and it's inherent that you're born with these cells outside of the uterus, so once that lining starts developing, if I understood you correctly, it begins to grow.
Yeah.
Then I don't know if you would be able to do like a vaccine or something like that, would you? Because it's inherently genetically going to grow there.
Yeah.
And I don't know anything.
There's two different ways. Yeah, no. So that's a good point. So there's two different ways to use vaccines. The way that cancer vaccines are being used is after diagnosis, which is a little counterintuitive because we think of vaccines as mostly preventative.
Yes.
So there's like a ovarian cancer vaccine, a breast cancer vaccine. So I think initially people would be diagnosed with endometriosis. They would have everything removed, and then they would potentially get the vaccine to treat microscopic disease that maybe was missed because our eyes aren't microscopes, or maybe it would prevent recurrence. And then eventually maybe we could transition to preventative. So if you gave the vaccine before she started having periods, maybe the immune system could just go clean up all those cells before they started like acting up with her first period.
Right.
This is all totally hypothetical.
Sure.
Totally hypothetical.
No, but it's I mean, that's how things start, is throwing ideas out there, throw it at the wall and see what sticks, right? I mean, you obviously know way more about this than Hamper I do, but
So what are the chances of you and an OBGYN working together? Here's my business card, blah, blah, going on and
yeah, I've got a lot of OBGYN colleagues who are great and refer patients to me, and I refer patients back. So that does happen.
Okay.
But it just doesn't happen as often as we would like.
Because I see the girls come in to see the OBGYN first before they come see you.
Right.
Yeah.
Well, they should, right?
Yeah.
I mean, they should have one. And
I mean, patients are either referred to me by their general OBGYN who says, this surgery is too complicated for me, or, some OBGYNs have just stopped doing major surgeries because they recognize, I'm mostly delivering babies, I'm doing surgery infrequently, maybe this is not great for patients. And so patients either get referred or they find me on their own. There's a lot of different ways patients get to specialists, but unfortunately, right? Yeah,
you never know.
Google search. A lot of patients say they're finding me on ChatGPT now, which is kind of crazy.
Oh,
so,
really?
Yeah.
Look at you. You're an AI. That's good though. It's good that you're getting out there. People are being referred to you, and you're doing something. You're making a difference. So that's awesome.
Yeah. Well, I think all young ladies should get checked out.
I definitely, if they're hitting the markers. I mean, yeah, it's very common. It's very painful. I've seen it firsthand, and it's scary. It's very scary. Let's kind of start to wrap up on that. What would you tell young ladies to? I mean, I know we've covered it, but let's just kind of put at the very end of this.
Like, recap it.
Let's recap it. What are they looking for?
Okay, take home points. Extremely painful periods are not normal. Mm-hmm. If you're missing school or missing work, or you can't walk, or you're passing out, that is not normal, and that should be that's endometriosis until proven otherwise. So that's take home point number one. Take home point number two is if that's happening, go see a doctor, either your primary care doctor or your OBGYN. And then if you feel like you're not making progress there, you can always ask for a referral to a minimally invasive gynecologic surgeon, an endometriosis specialist, or you can seek one out yourself.
Okay. All right, perfect.
And a specialist would be her. She's a specialist.
Would be you,
yes.
Dr. Brooke Winner. Tell everybody where they can find you.
Yeah, so my new practice is Full Spectrum Fibroid and Endometriosis. We're at fullspectrumgyn.com. You can also find me on Instagram, dr.brookewinner. And if you just Google my name, Dr. Brooke Winner, everything pops right up.
Perfect. Have you got any of those?
Nope, good. I just got my notebook closed and glad I'm a man.
You check any of the boxes? You think you got endometriosis? No, you good? You good? No more surgeries for you for right now, right?
No.
How's your hand doing, by the way?
I'm supposed to have an appointment on Monday, tomorrow.
Yeah.
To tell me he's going to schedule surgery, but I can't do it.
So Hamp had his knee replacement, and they laid you on your arm?
They laid me on my arm too long, and then compressed all my nerves, and all this is numb.
Oh.
So
Sometimes that'll get, but that's like a positioning injury from surgery. They're rare, but they can happen when you're like sleeping in your bed at night and there's a pressure point, you sort of unconsciously shift around. But when you're in surgery, they have you paralyzed. And so we do our best to really make sure your arms and legs are in a neutral position and pad everything. But occasionally a nerve does get, kind of compressed. And usually
6'9", 300 pounds.
Yeah, that is a risk factor. But sometimes that'll get better on its own, but unfortunately sometimes it doesn't. So
it's been since April. So
surgery is not without risks.
Yeah. Is there a surgery so do they want to operate on you?
Yeah, they want to. He said he want to go in here and he want to go in here.
And what do they do for that?
I'm not sure what he's going to do, but he said.
Do you know? I mean, I know this isn't your specialty, but
A nerve graft? Maybe that seems like a long graft. I don't know.
No, if somebody what that test I had, EMG.
Yeah.
I'll slap the hell out of somebody if they tell me I have another EMG.
Was it painful?
Oh my God.
Oh, my mom just had to have that done.
Oh, really?
I need to talk to her more about that.
Yeah.
Call your mom.
It's painful.
Yeah.
What was it? I remember you said it hurt, but what did they do?
Well, first of all, they put these pads on you and they kind of run electricity through it. Then they take the
it was like a needle, right?
Acupuncture.
Needles.
Okay.
They're measuring the electric impulses in the nerves to see if they're conducting.
Registering.
Yeah.
From here all the way down to my hand, in the hand.
And acupuncture is not supposed to hurt, but they're going to the nerves to hurt you.
Oh, it was stupid. I wanted to choke her.
This is different than acupuncture.
Yeah.
Both involve needles, but that's probably the extent of the.
Yeah, it was painful. So just make sure you tell your mom. It's very painful.
Okay.
Well, hopefully you get that taken care of.
I'm not getting surgery.
Because my catfish career is over.
I can't afford to do surgery right now. I got to drive a food truck, run a restaurant. I can't do it.
Awesome.
No.
Well, I want to say again, thank you very much. You've been a blessing to my daughter and I. Like, I know you do this every day, but from my point of view as a father, as a parent, to see my daughter in pain every day and not know what was happening was terrible.
Yeah.
And to see her, and like you said, even now the pain from the surgery, it's nothing like what she was going through before.
Yeah.
I mean, she's in a better mood already.
Yeah.
She's having a tough time getting around. She's hurt and she's sore, of course, but it was debilitating what she was going through before, and this isn't just the healing from the surgery, and once that's done, I can't wait to see. She's probably never had, I was thinking about this the other day, she's never had a real normal life because it started when she was, 11, I think.
Some ice cream.
She's got ice cream. She got cheesecake right now. She's got.
Oh, she's fine. Then.
Viddy's here. She's got all the sweets. My oldest daughter's a cook, so they got all the food and all the things at the house for sure. But anyways, thank you very much. I can't wait to see how she does. We'll do a podcast with her after that and get her side of things as well, so she can talk to young ladies about how
we would like
to
get you back up here with Tina as well.
Yes,
So
we're working on that.
Push that bill somewhere along the line and have a conversation between you two and go from there.
Excellent.
Yeah, for sure.
Well, thank you so much for having me.
Yes.
Thank you for helping to raise awareness. It's awesome to see a dad advocating in this space. So
Thank you.
You guys are great. Thank you so much.
Thank you very much. Take us out, Joe.
Take us out. Stick Lounge Podcast, guys. Thanks.
Joe and Hampton, lights dim, it's game time. Interview sharp, cut through like a shank line. Stick Lounge stories unfold, real and raw. From hustlers to dreamers, breaking laws with a claw. Microphone warriors, capturing life's conflicts. Sitting across legends, tales flick like black pics. Drop bars, not mics, knowledge, it rains. From the streets to the beats in every vein. Stick Lounge Podcast, tales heavy with the weight. Real lives, gritty stories, never